Let me introduce the next speaker, Dr. Srini Godawithanage. She's going to speak to us on vertigo, the central causes and how to do the HIMSS examination. Over to you, Srini.
Vertigo, and this topic also mentions HIMSS, and I will try to illustrate what this is about this vertigo. So I'll try to do this in a very simplified chase sequence, in which I will first do acute vestibular syndrome that we commonly encounter. This is usually in the emergency department. We need to differentiate among vestibular neuritis and cerebral infarct. Then I will move on to benign paroxysmal positional vertigo, in which there's vertigo triggered by a position which has a unique pathophysiology, bringing on its own clinical signs. Then I will move on to the most common causes we see in the clinic setup. Usually it's a mid-grade, and how to differentiate that from a less commonly occurring venous region which comes to our clinic. By illustrating the physical signs of these three scenarios, ultimately we will get to know the features of central vertigo as well as features of peripheral vertigo, so that we can apply that knowledge to a rarer causes of vertigo, like a multiple sclerosis in the central causing a central vertigo, or vasculitis causing a central vertigo. Likewise, we can apply that the same knowledge. So before going ahead with a patient, we need to clarify what the patient is going to tell us, whether it's really a vertigo. Because patients use the term dizziness interchangeably to denote different symptoms, usually for a syncope and for a disequilibrium. A syncope usually is a feeling of a lightheadedness, a general weakness, clouding, and a feeling of faintishness, which we see in circumstances like anemia, cardiac arrhythmias, metabolic disturbances, dehydration, so which is different from a vertigo. Disequilibrium, patients also tell it's as dizziness, but it's just that it's an imbalance when the patient is trying to stand or walk. But what we are going to talk about is vertigo, which is a sense of motion, where we see the environment is spinning around, whirling, and this might associate with vomiting and imbalance. So it is a feeling of spinning around. It may be the patient see that the world is spinning, or it may be that the patient may feel is spinning. So how does this vertigo how does it occur? It is to do with the vestibular system and its connection through the brainstem, and through the brainstem, its modulation of the influence on the eye muscle is to do with vertigo. I will try to illustrate this as we go along. To explain this, I will show you what is this oscillopsia is. This happens when there is absence of bilateral vestibular function. So this is a patient who has loss of vestibular functions on both sides. What happens is when he is walking, his visual field shakes. So that means he cannot compensate for the head movements. Usually the vestibular system, when your head is moving, it operates to influence the eye movements to make compensatory movements and stabilize the visual field in the retina. So when the vestibular function is not there, this does not happen, and this oscillopsia happens. So you get some idea what the vestibular system is causing. So vertigo is, I mentioned that it is a feeling of rotation. And this is to do with the semicircular canals. It is the semicircular canals that sends the rotatory movements of the head. So it is the semicircular canals that rotation and make adjustments to the eye. So it is an imbalance in the semicervical canal activity that causes vertigo. There is a fascinating system of generating this impulse, but I will not go into that. But just to illustrate the fact, what happens is in the baseline, there is a burst activity which is symmetrical on both left and right semicervical canals. So it is exciting at a basal level. So when you are moving the head to one side, there will be more activity on the side that you are turning the head. And there will be an inhibition on the other side. So there is this imbalance. This imbalance is the one that vestibular nuclei creates the sense. So this imbalance is sensed as a turn of a head. So what happens when there is a vestibular pathology? So the baseline activity on that side is lesser or may not be there, but the normal side is still working. So there is an imbalance. Imbalance is normal side activity more than the affected side. But the vestibular nuclei doesn't know anything about it. It just only says that there is an imbalance. So even though the head is not turning, now it is understood that there is a head movement. But the other cues like visual cues is telling that the head is not moving. So there is a discrepancy in input which causes vertigo feeling. So also to the affected side, there will be a slow movement of, there will be a slow eye drift, eyes will slowly drift to the affected side. But the central system picks this up and make a corrective movement to bring the eyes back to its normal position. So when there's one side is affected, eyes tend to slowly move to the affected side, and there's a corrective movement of the eyes back to its original position. So when this happens again and again, and it appears as a nystagmus where there will be a slow component moving to the affected side and a corrective movements occurring to the normal side. So this the essence is that this is there's a reflex called vestibulo-ocular reflex, which is the one that operates in this circumstance. So if a patient, even if you look at an object and when you are turning your head, we usually keep on focusing on the same target. Eyes doesn't move with the head to the other side, but eyes are moving up to the opposite side and keep on the target we are focusing. For that to happen, for instance, if I move my head to the right side, I should move the opposite way. For the eyes, both eyes to move to the opposite way, the left lateral rectus on that side should move, and the medial rectus on the right side should move. So there's a lot of coordination to bring the eyes to the proper position. Here we had a video in which you can even do that. If you look at the topic there, and if you keep on moving your head, you will still be focusing on the sentence and will be able to read it. That is what this vestibulo-ocular reflex is doing. This is the same thing I just described you. When the head is moving, the eyes are moving to the opposite side, and we are stabilizing the image on the retina. Vestibulo-ocular reflex, which stand across the midbrain pons and influence the eye muscles in an appropriate manner. So we are stabilizing the image on the retina without any shaking of the visual world. We can test this at bedside by what we call a head impulse test or head thrust test, in which we ask the patient to target on our nose. We ask the patient to keep a visual target on our nose, and we ask the patient to relax, and we are going to turn the head, and we are going to see whether the patient is able to keep focusing there without losing the target. So you suddenly make a jerky movement and comment. In a normal person, eyes should keep fixing on the target without shaking anywhere. So this, I don't know whether you can see, eyes are not moving. There are no jerks. So it's remaining there. So it is a normal test. So we will see what happens in an abnormal test. Now the patient is shaken to the right side of the patient, then to the left, then to the right. Do you see anything? There's a little movement on the right eye. Here. Now come. There's a little jerky movement on both sides, correcting the eye to come back to the central position. So that is the saccade we are looking for. So that means the head impulse test is abnormal. So that means the patient is not fixing, eyes is slipping. So the central system have to make a correction movement to bring it back to the center. This is a bedside test. So we now know from the basis I have explained, if there's a jerky movement in the head impulse test, it is positive and it points towards the vestibular pathology, which we call a peripheral vestibular pathology. So with these things in mind, we will look at few cases. What we are trying to do is, in the emergency department, to differentiate vestibular neuritis from a cerebral infarct. So vestibular neuritis is a peripheral vestibular pathology, and the central one is the cerebral infarct. So this is a simpler case scenario. 52-year-old male patient with hypertension, diabetes, coronary artery disease. Now comes with an episode of sudden vertigo, double vision, left facial numbness, and a gait unsteadiness. He needs support to walk. This has started 30 minutes ago, and his blood pressure is 130/90. So it is a patient with a lot of vascular risk factors coming with a neurological deficit of short duration and acute onset. This is like a stroke. And there is facial numbness also there. So it is pointing to a central pathology. We are not getting facial numbness in the vestibular origin pathology. So this is an easier case. So if you have associated neurological symptoms, there's nothing much to worry. There's nothing much to differentiate also, but you will localize and proceed as in any other stroke. So what strokes are usually, the cerebral strokes and lateral meningeal strokes are the ones that we mostly see a lot of vertigo. So this is a lateral meningeal infarct. In this, we see a lot of clinical features. Corners on the same side, facial sensory on the same side, opposite side sensory, hoarseness, and so on. So it is a brainstem we are capturing in these strokes. There will be a lot of, there's chance that there will be a lot of physical symptoms and signs. So there can be ataxia, sensory, motor, dysarthria, voice changes, visual field defects, and so on. But if anything of those are there, our job is easier. It directly points to a central cause. Then we look at another patient who is a 40-year-old male admitted with a persistent vertigo. But waking up that morning, the patient noticed that his balance was not quite right. After arriving at work, his symptoms got worse and he experienced severe vertigo, vomiting, and ataxia. So it is an acute case of a vertigo. And he had no headache, no hearing loss, and no focal neurological symptoms. Here notice that we always ask in the history whether there's any auditory symptoms or whether there's any clear-cut symptoms indicating that there's a central involvement. So in a history, you will take it that. Then this patient was recovering from an upper respiratory tract infection, and on examination there was a spontaneous nystagmus. I missed that slide earlier because of this mix-up. When I described that the nystagmus is occurring in a vestibular pathology, I said there will be a slow drift of the eye movement to the affected side and there will be a corrective movement to the opposite side, normal side. So, because there's pathology is always on this one side, this correcting faster nystagmus will always be to the opposite side. In a nystagmus, we always describe it according to the faster component. So if there's an involvement of the vestibular organ, there will be a faster component always to the opposite side. So it is a unidirectional nystagmus. So we see in this patient, at resting position also he has a nystagmus. And it is checking, can't say the direction there, but yeah. Go again. So that's a faster jerking to the left side. Again to the left side. But lesser again to the left side. So it is always to the left side. So it is a case of left feeding horizontal. Did you see that there was a little rotatory movement also which we saw onto the left case mostly when it is maximum there. So it increased looking to the left with obese rotatory component. On looking to the right, it lessened. So these features will be important in combination at the end. So there was a unidirectional nystagmus. So then we do this bedside test to find out whether it is of central or ventral origin with this contrast test. Did you see there? It was coming back, it was jumping back. So there was a corrective secondary movement. That means that side, there's a problem. So that means our head impulse test is positive. So that we know that now that if the head impulse test is positive, it's a peripheral vestibular problem. So this is abnormal head impulse test. So it indicates the problem is in the periphery. So it is in a way reassuring for us because there's nothing wrong in the central areas. So in summary, this is if you get a unidirectional nystagmus, it is a peripheral vertigo. And if the head impulse test is abnormal, it is a peripheral vertigo. That's what we saw in this patient. So it was taken as a vestibular neuritis. Because in the emergency department, it will be a clinical diagnosis. Early in the presentation, CTs will anyway be normal, even if there is infarct. So there will be a clinical differentiation. So you go to another patient, 65-year-old female with diabetes, hypertension, reports acute onset severe rotatory vertigo. So it is an acute case of vertigo in the morning. She complains blurred vision, jumping images with its vertigo and tendency to fall and with nausea and vomiting. So it is an isolated case of vertigo. There are no clear-cut auditory symptoms or other clear-cut involvement of central areas. So our job is to differentiate it from acute stroke or vestibular neuritis. So we rely on the clinical examination as in the earlier patient with the head impulse test that nystagmus on this patient. So this is the head impulse test. Even being older patient, she keeps on focusing very well without any slipping off her eyes. So it is a normal head pass test. So the normal ones, we worry that when there's anything wrong in the central areas, whether it's an impact or maybe a hemorrhage. This is the same patient examination of nystagmus on the same patient. If you see there's a beating towards the right side, and when you're looking, it goes to the opposite side. The right side. It is to the other side. So it is a direction change. So this was a horizontal nystagmus, initially to the right, then on to the left. This is a direction changing nystagmus. We call a gaze evoked nystagmus. So far, this is the same thing again. So direction changing points us towards central cause. And this, if it is pure horizontal, pure vertical, especially if it is pure vertical, it indicates a central cause. So this patient had a cerebral infarct. So it is the way we see a central case of vertigo. So characteristics of central nystagmus are they have normal head pass test. Their direction of nystagmus can change. There can be it will be purely horizontal or purely vertical. You don't see a combination of horizontal and vertical, horizontal and rotating components like in the vestibular neuritis patient. And we have other features which we call skew deviation. And this Alexander Lowe, I will skip that part. So this is another examination we have to look so that our findings will be more strengthened. This is a cover test. What we are looking is whether the eyes are aligned properly. Here you see when we are uncovering the right eye, there will be a corrective movement coming back. That means there's some misalignment in the right eye. So there's a vertical misalignment. So in this test, we find out it is there. That happens in the central cases of vertigo. So we come to this hints I mentioned in the topic. So this is hints means head impulse and nystagmus and this test of skew. This is the test of skew. That means that we are looking for a misalignment. So it was published in 2009 and this study showed that bedside examination of these three of these three findings is as good as or maybe better than MRI even in the acute setting. Because in the acute setting, it will be a clinical diagnosis. Right? So I didn't mention this earlier. We so far described only this gaze holding according to the head movements. But there are other scenarios in which there's a lot of mechanisms to keep our visual images still. For instance, if we keep our head and if we want to see a moving target, eyes will properly follow it. We have no problem, it doesn't shake. And if we want to look at a target from somewhere here, our eyes will move and focus directly onto that without overshooting and going here and there. So there's a lot of other brainstem centers that work on this other visual stabilizing method. So it is brainstem is a small area. If there is a central problem, we are very likely that we will pick something up in the eye movements. So it is an important examination in a patient with isolated vertigo. Usually, if it is a vertical problem, the chances are it will be something wrong in the midbrain. If it is a horizontal problem, it will be chances are that it will be in the pons. So we can get to a fair clinical localization even at the bedside. What we are calling is whether the patient is able to move both eyes together, whether there is asymmetry, like this misalignment, those sort of things we can have a look. I don't know how many of you have saw what I showed you. So it's not very easy all the time. Some patients make compensations and we don't always see the nystagmus. So there are other advanced techniques like video, nystagmography and so on. But again, this takes time and it's not a practical way to do it in the emergency department. Therefore, this bedside test still becomes important. So that will conclude my first segment, and then I will move on to this other part. Where we see recurrent, triggered, positional vertigo. This is the specific situation where we see a very short lasting, usually up to 1 minute or 2 minutes, which comes on a particular head movement. This is benign paroxysmal positional vertigo. If you get the history to that, you will do a very targeted examination to trigger that vertigo by positioning the head in that plane will bring on the vertigo. So there are this I mentioned earlier also. These semicircular canals are oriented in specific planes, 3 on either side. So commonest we see in that is the posterior canal, BPPV. What happens in BPPV is there will be this small calcium carbonate particles detaching from the utricle and falling into the semicircular canals. So that will disrupt the normal circulation of the endolymphatic fluid here. So that will give a false impression that head is moving, because it's not the normal fluid movement, but there will be abnormal movements because of these particles moving within. So what we do at the bedside is we try to move that particle and try to elicit the vertigo that patient is experiencing. So usually it is the posterior canal that results most of the time. So for that we do what we call a Dick's fall pipe test. That is to bring the posterior canal into the plane so that the particle will move along. That will bring on the typical nystagmus. So see, it is on the right side, it is a counterclockwise rotatory upward movement. So the thing with this nystagmus is that it doesn't come as soon as you move the patient to that position. There's a little delay and it will increase afterwards and it will wear off. This is to do with the pathology of the this BPPV. It will need a little time to bring the stone to move. So that is why there's a latency. And it will increase then with time this particle will disperse within the canal and the stimulus will go away so that nystagmus will die down. If you do it several times, it will not be that intense on the second and third go. So it is important to know all these features because we need to find out whether it is a typical case of BPPV. If there are atypical findings, in a rare case, can be of a central cause. So this is again the same thing, a patient scenario, a typical one we see. Usually we see them waking up in the morning and not being able to turn in the bed or not being able to bend down. So 56-year-old woman, diabetes, hypertension, dyslipid, severe vertigo, unsteady nausea, and started in the morning. She has several exacerbations since then, each lasting 30 seconds, especially when turning in bed. And examination when doing seated is normal. No spontaneous nystagmus or gaze walk nystagmus, so it is normal. So in this BPPV, when you positive canal especially, when you examine the patient seated, it will be normal. If the patient stays still, patient will be symptom free. But unfortunately, our patients are not that descriptive and they don't tell it's a 30-second vertigo that worsen with turning head. But if you ask often, they are able to elaborate. So this is the Dix-Hallpike test. So if a patient coming with short-lasting vertigo turning in bed or bending forward, this is the test we do. This is the Dix-Hallpike test. This is that patient we described. You clearly see this, it is there. So easy bedside test, and if you see, there is a way of turning the patient in a serial manner so that we can move the stone out of the canal. So it is just 2 minutes job, and you can cure the patient most of the time. I will not show that. It is called Epley maneuver. The vestibular sedative is not going to help anything other than sedating the patient. So this is the only way out. So I mentioned there will be rare cases where central causes might mimic. You can suspect it if the patient is not improving, and if the nystagmus is not very typical as of a typical BBTB. So with that, I will move on to the next scenario we see commonly in the clinic setup, that is, we go to see the recurrent position of vertigo. This is not a triggered vertigo we are telling, but there are recurrent episodes of vertigo. In this circumstance, shortcut to different keys establish the duration of vertigo in the attack. We so far, from what I described, you know that if it is a very short lasting 30 seconds to 1 minute, it's going to be PV, and you can elicit the typical signs. So if it is going to be more than minutes, hours, or days, in the clinic we mostly see it's a migraine patient. A TIA can cause different time durations like seconds to minutes, hours, but then it's not going to be recurrent and unlikely we will confuse it. And stroke event is not going to be recurrent. So we have to differentiate menias from migraine. So this is another patient, 51-year-old woman, who noted sensation of her right ear being blocked in the morning, now has speaking, decreased hearing. Then this vertigo comes, then began to spin wildly. She became sweaty, nauseous, and vomited, spinning about 60 minutes in this case, and it improved. She has now a little residual distinctive. This is a typical patient with a manias. The auditory symptoms points us to the etiology of mania. It is the feeling of blocked ear with tinnitus, and hearing will decline with the attack. But it might happen that patient not exactly tell, but if the hearing is impaired with time, and if patient is having severe vertigo episodes, we will consider this. So this vertigo lasts about, maybe it can last about 6 hours to a day. Like in a rare instance, if the patient is not that descriptive, we can confuse it with the migraine, which we see more commonly in the clinic. So this is the last case scenario. A 30-year-old teacher assisted leave because of disabling work. She described attacks lasting between 30 minutes and several hours, suffering 1 to 2 per month. So it is again a true vertigo with nausea, vomiting, unsteadiness, and attacks resolve spontaneously. And there's no headache or hearing loss or any other neurologic, and examination also remains normal during the attack. So it is a vertigo that is lasting, it's not seconds, it's not a minute. So it is not going to be PDD. And there are recurrent episodes. And she doesn't have any auditory earfulness or nothing or tinnitus. So it's not going to be many years. So the commonest we see like this is migraine. But migraine can have variable presentations. Even a normal migraine without vertigo or vestibular symptoms will have a motion sensitivity and dizziness. But there are patients who will have typical vertigo attacks, maybe with the headache, but sometimes some episodes even without headache. So there are diagnostic criteria for that. Obviously, we have to exclude the other causes and can have a look at the therapeutic response. If there are there, we can look in the history to see whether there's a definite migraine with aura. So it is important for us to, if there is a relapsing case of vertigo, fish around to see whether there's a migraine history. So other common things I'm not elaborating, but we see commonly is these medications, alcohol, antibiotics, and long duration treatment with antiplanoids like for endocarditis. You can have this vestibular symptoms. And another common cause is trauma, where you can have concussion, can cause vestibular symptoms, or maybe it can trigger a BPPV. So I'm sorry there was a lot of trouble in showing the video, but with that time, this patient was supposed to move a lot there in the cord, but it's not coming. I only elaborated on this vestibular mechanism stabilizing the visual field. But there's a lot of other things going on with the head movement. Our body is oriented, stabilized. It's a lot of spinal reflexes also. So these patients have more symptoms, unsteadiness, disequilibrium. And there's a major part of a major compensatory mechanism in ourselves also, mostly with the visual system. So it might happen that all the patients will not have all the signs. Some people are able to suppress it. So not every vestibular neuritis patient will have nystagmus. Some people are not showing it, but there are ways to bring it on. Because I wanted to simplify, I have skipped all that. With that, I will conclude and thank you.
Thank you very much, Srini, for that excellent outline on the vertigo management. When we encounter a patient with vertigo, one of the key questions we have is whether it's a peripheral vertigo or a central vertigo. To answer, the short answer is to go for MRI scan. Certain lesions will be shown up on the MRI. But Srini showed us how you can avoid getting it. MRI website you can differentiate central from peripheral vertigo.